Hello everyone, welcome again to the Race Academy webinar series. We have a very exciting webinar today. We're coming to you live, along coming to you live from Sydney. Hence, whilst I have this mask on, very strict lockdown procedures, which we plan on maintaining safety for both ourselves, our staff, our clients, and ultimately our patients. So I'm hoping you can all hear me. We hope everyone is keeping safe. We hope you're all doing well. From Sydney, it's a challenge for us now, but we are remaining open to serve you and the rest of the country and other countries should you need us. We will be remaining open and we will be doing everything we can to remain COVID safe during this lockdown. But today, like I said, we've got a very, very popular topic. And one of the biggest questions I get asked in our removable department, there's so many different types of splints and the management in use of those splints can be a little ambiguous at times. So we've got the best person we can to come on in here with Professor Michael Stubbs. And we're hoping you can share, Professor, some of your knowledge around the important role that these splints play in therapy, in management of bruxism. So with no further ado, I'd like to hand over to Professor Michael Stubbs.
Thank you. Thanks, Matt. I always feel great when I come on these invitations because you make me feel bigger and better than I really am. But thank you so much. It's an interesting topic, and one of the things as an oral medicine specialist I do a lot of is treating people with chronic pain, and obviously temporomandibular disorders, or TMD, is a big area that I deal with, but also bruxism is too. And I thought it would be really interesting to talk a little bit about the academia, perhaps, about bruxism, a better understanding of what bruxism is. And then I'd love to touch on some of the relevancy of topic for our clinicians and talk a little bit about splints and splint design. So we'll begin. So bruxism is an interesting term. It just simply means to gnash the teeth. And it really is by definition a process where you're getting this jaw muscle activity of clenching or grinding of the teeth and bracing or thrusting of the mandible. So if you think about it, what we used to say was, do you clench or do you grind? Well, really, bruxism incorporates both. And I think it's probably fair to say that most people from time to time will either brux at different stages of their life. They tend to do it periodically. They tend to do it sometimes a couple of nights and then nothing for months or years even. And more importantly, the specifics, do they clench or grind, probably is not that imperative. But I have to say, one of the things I've learned from experience is, you say to your patient, do you grind your teeth? It's probably a very unfair question because how would they know? And if their partner's complaining, then probably. But remember too, folks, that clenching is silent. And so there's no noise, but it's happening. And I think this is a recording which I'd love to share with you because this is one of my patients actually who was bruxing. And he very kindly allowed me to use the recording for the purposes of presentations, and I'd just like to play this. I hope everyone can hear
that. Professor, I'm having a little bit of trouble hearing that. I'm not sure if the audio works again. Could you just give that another go, maybe?
No worries at all. I'll just try. Whoops.
There's a volume. Oh, yeah, okay.
Any good?
I can't hear it personally. I just wanted to let you know.
Right. Well, dare I say to you, for the purposes of those, sadly, that couldn't hear that, I heard it quite graphically here. It's like nails on the chalkboard. Okay. And the thing is, this gentleman, he had an issue where he came to see me because he was tired. And naturally, people assume sleep apnea. And because he had the grinding of the teeth, or bruxism, as you could hear, or those of you that could hear. In reality, the reason I put this up is that sometimes it can be profound. And we also recognise that if you think about somebody, let's say, who's regularly bruxing at night, one of the things you think about, don't you, is your restorations. You think of mechanical wearing of the natural teeth, and more importantly, too, the likelihood of fracturing of our teeth, as well as tooth pain. And we understand that for some patients, having a bruxism issue can occur as a result of what we call obstructive sleep apnea. So you might say to me, what does that really mean? Well, it means that when you're sleeping at night, when your airway becomes blocked, stops breathing, and usually it's for more than 10 seconds, you come through this episode where your brain recognises the oxygen levels are dropping, the carbon dioxide levels are rising. And as a result of this mechanism, it switches you from deep sleep into lighter sleep. So your reflexes click in, so you start to breathe more easily. And as you do that, you get this supercharged sympathetic nervous activity happening. So you get heart rate increases, you get an adrenaline surge. And as a result of that, the masticatory muscles become very active. And part of the reason they do is it's thought to stabilise the open airway. And so you can see in this diagram, this is a very basic one of a sleep study. And we can see this is a recording, an EMG of the chin. And these little graphic marks here indicate episodes of movement of the chin, which is relevant to bruxism and also just the movement regularly called rhythmic masticatory muscle activity, which we'll talk about in another topic. But the idea is this is highlighting the fact that the patients stop breathing. And then they were breathing, and then they stopped breathing because they had the obstruction. The brain recognised the rise in CO2, switches in the reflexes, they start to breathe again. And so obviously then the chest movement starts to return to normal, airflow through the nose occurs. But what's interesting is through the process of apnea, you see the activity up here. And that's actually the bruxism. So it's like a surge of activity that happens after each event. Now imagine if you can, you stop breathing through apnea 20 or 30 or 40 times an hour, eventually you could have these bruxism actions happening 30 to 40 times an hour, every hour. And the reason it's relevant to talk about is because when someone you suspect might have bruxism, sleep apnea is one of the reasons. But it's important to know, folks, it's not the only reason. And that's what I'm going to talk about as well. And so we view and always have thought bruxism, why do you get pain? Well, that's an interesting one as well, because not everyone that bruxes gets jaw pain. And, you know, when we talk about academia and we say, well, you know, does people that brux their teeth, they automatically have sore jaws? Not always. Some patients will tell you things like when they wake in the morning, their jaw's stiff or sore. You could easily, in my view, interpret that as there's been a bit of activity at night. But sometimes patients brux, and they have done for many years, and in fact, they don't tend to have any symptoms of jaw pain or stiffness of the jaw at all. And we also realise that not everybody bruxes at night. So as I said earlier, it's estimated that about 14% of children have sleep bruxism, and we estimate 8% of adults brux their teeth at night on a regular basis. And believe it or not, when you get over to this golden age of 65, which nobody watching this, of course, would be in that category, you get more, about 3%. So there seems to be a shift in the frequency of the events too, based on age. And we recognise too that sometimes patients get wired up for a sleep study. You can often request what they call an EMG tag, which sits on the masseters or the submentalis region, and you can record if the bruxism's happening. But sometimes you can wire somebody up for bruxism and they don't always necessarily brux that night. So it does vary night to night, person to person. And usually patients who tend to have issues with the sleep bruxism, or they may have sore jaws in the morning or stiffness of the jaw, but during the day, people that tend to be aware their teeth are clenching or grinding their teeth during the day, one of the reasons, most common reasons, is anxiety. And again, it's not the only reason. I'm going to touch on that. I thought for the purposes of just explaining what sleep is, and again, I'm only going to briefly touch on this, you might recall from the previous presentation I gave, we talked about sleep being light sleep, deep sleep, and we called REM. So REM is the dreaming part of sleep. The deeper part of sleep is important because it's a process where during that time frame we generate some growth hormone, which is important for body repair. And the lighter stages of sleep is really when you're starting to close your eyes, probably for the first 20 to 30 minutes. Interestingly enough, about 80% of bruxism tends to occur in lighter stages of sleep. And one of the views I have is that's one of the reasons why some of the patients know they're bruxing, is because when they wake up in the morning, they'll say, oh yeah, I'm aware I'm clenching my teeth. And we also realise about perhaps 10% tends to occur during the REM phase or dreaming phase. Again, there are different reasons for that. One might be because if they have sleep apnea, as I've just shown you earlier, they tend to brux after the event. And two, some of us also know that when you're dreaming, you tend to yell, shout, you can move around in bed. And we call those movements a dystonia, a useless body movement. And that's how we view bruxism. Bruxism is a dystonia, a useless body movement. And we also realise that sleep bruxism has been linked, as I said earlier, to morning headaches and jaw pain. I think that's very reasonable. Again, with headache, remember it can be neck pain that's causing headaches in the morning. It can be sleep apnea, which you get headaches in the occipital area in the morning. Lots of reasons. Dehydration, a big night out, officially known as a hangover, and those type of things can be a factor as well. And we also realise that sleep bruxism has been associated with tooth wear, remembering too that diet can be a factor in this equation, and facial muscle pain is also a reality. And of course, other things like medications, commonly prescribed medicines, which I'll touch on in a moment, can also aggravate bruxism. And as I've already touched on earlier, obstructive sleep apnea can also be a factor in contributing to bruxism. Alcohol ingestion is interesting. Alcohol, the only reason it causes increased aggravation of bruxism is because it relaxes your airway. So you probably tend to get, if you have a narrow airway, you tend to, snore more, but you also do tend to find that if you have an apnea issue, it's going to increase the apnea and hence the bruxism. And as I said earlier, it can occur in different times. So not everybody grinds every night or clenches, but there are people that do. I think the important thing in science, there's no actual cause and effect. As dentists, we love to say, if you've got this problem, therefore this is the solution. It's fair enough. We're practical colleagues. We treat patients in a world where we have to do treatments for outcome, but there is no actual causality between every person that has sleep apnea and they brux. There's not every person who has a bruxism issue has sleep apnea. Likewise, not every person that bruxes has temporomandibular disorder either. But I think it's probably fair to say that there is a fair association between the two. So again, if you're having a look at a patient and you're examining their jaw and they're talking to you about waking in the morning with a painful jaw or stiff jaw, I think it's reasonable to conclude that there is some element of bruxism happening. We also realise that sometimes some patients can suddenly find this uncontrollable movement of their jaw when they're clenching or moving their jaw like I'm doing now. And there are some rather rare or interesting neurological conditions. So I suppose my thinking for you when you're watching this would be, if you get somebody that comes and sees you, perhaps if you had the opportunity to know them for a long time as a patient, and they suddenly tell you, look, they've noticed that they're clenching all the time during the day. First thing you might think of is there an anxiousness to it, the issue? But if you're not convinced or not sure, having them see their GP is very relevant. In rarer cases, there are some interesting neurological conditions where it makes the jaw work hard. And these are called those dystonias. And sometimes people have this uncontrolled movement. Now, I know that might look like a humorous slide, but this gentleman has been on a drug where it's used for the treatment of psychotic disorders. And sometimes what happens is that tardive dyskinesia. So he has this uncontrolled tongue movement, but he can also get a lot of bruxism happening. And the one on this side, which you may not hear the sound, but you'll certainly watch the movement, is I took from the web from a neurologist colleague where, in fact, he actually has this uncontrolled head movement. But the reason it was relevant was because, again, this is suddenly just developed. He went and saw a neurology because he couldn't stop doing this. And he suddenly started to get this bruxism issue as well. And so the idea of just showing you this is just highlighting the fact that when he held his hands up, he stopped moving his head. And then as he put his arms down, the head starts to move again uncontrollably. The relevancy of me showing you these things is sometimes even in our professional lives, we treat people. And so sometimes things can change and you might be the first person that recognises that your patient that you've known for a long time suddenly has got this uncontrolled bruxism. You might make some inquiries. Do they have sleep apnea? Are they on a new medication? Have they developed a neurological disorder? Granted, a rare commodity, but discussion with the patient's GP, quite valid and reasonable. And we also understand that medications can be commonly attributed to increasing the bruxism. And that's the most common reason why, other than, say, sleep apnea or perhaps anxiety, is a cause. People might be on a drug called Ritalin. attention deficit hyperactivity disorder. We know that happens in kids. It can be diagnosed in adults as well. Ritalin is a stimulant. It keeps the impulsive behaviour, which is what causes ADHD, seems to control it. The problem is, like a dexamphetamine, it causes this increased bruxism tendency. And so patients can start to strip their teeth, literally, because of a side effect related to medication. Ritalin also has the impact of drying the mouth out, which can also increase the likelihood of tooth sensitivity and enhance the loss of tooth structure.
Professor Stubbs, I've just had someone interject asking if there seems to be a rectangle in the, I guess, the cervical third in the middle of the screen. Is that removable on your end, or it's telling me to remove it but I'm unable to do so? Can you move that? Because all I can see is blocking a small part of your
Oh, right. Okay. How's that?
It seems to be coming back again.
Yeah, I'm not sure either how to remove that. I'm sorry.
Oh, no, right. It's not too big, so continue on, mate. We'll work around that.
Sorry. So these are some of the more common medications that people would take for anxiety or depression. And so particularly those of you watching this in Australia will be familiar with some of these more common brand names. Different countries, different brand names, but the drugs citalopram, these are particularly used for anxiety, obviously depression as well. The side effect of that is it increases the stimulation to cause the increase in bruxism. So again, if you get a patient who presents with a sudden increase in jaw pain, you might inquire on the medical history and say, well, have you been on this medication recently? And they might say, yeah, I've just been put on an antidepressant. I think the thing that's important here is to say it's not suggesting in any way you say to the patient, oh, you've got to stop that medication because you're stripping your teeth. What we need to do is think about ways and means we can protect the patient's teeth. And that's where the value of a splint comes in. And these are some of the more common brand names which I've just put up there for the purposes of just demonstrating what they are and what patient may be on. And as I said earlier, we know that TMD and facial pain can also occur in patients who have bruxism, and it can also occur in patients who don't have bruxism. So again, it's just recognising that it may be and may have a role to play in the presentation of the patient's pain. So as we move on then, we already established that sleep bruxism patients often find they'll wake up in the morning, perhaps with a stiff or sore jaw, and the awakening bruxism, the sensation or the awareness that their teeth are constantly in contact with each other, can be related more to anxiety in about 40% of cases. So again, you might have a patient who says they can't stop clenching their teeth. It's a very difficult issue to manage, but I would advocate teaching them a very simple jaw exercise. In particular, one of the ones I'd recommend is get the patient to put the tip of their tongue on their palate, and then as they gently open their mouth, hold, count to 20, and then relax. It's a simple, easy technique to help separate the jaw. The fact the patient may be aware that they're bruxing is actually really important, because that's half the battle. And then having some kind of idea of recommending simple approach to that problem is also not easy, but it can be useful, particularly with the jaw exercise. We know that clinically, when we look at the mouth, we can see scalloping of the tongue, as we can see here. That's usually a dead giveaway that the patient has the flexing of the tongue in between the natural lower teeth, usually can occur in patients who have bruxism. Hypertrophy of the masseter muscles. Again, we realise that not everybody has a slim face. A lot of people have rhomboidal faces, and so you can get enlarged masseters genetically. But a lot of patients that you see who have real issues with bruxism, they often have very large, well-developed masseter muscles, a little bit like Arnold Schwarzenegger and his arm muscles when he does the lifts. And we know the linea alba here, you can see quite prominent thickening of the skin along the edging of the tongue. Notice the white areas here. This is where the skin thickens to protect itself, called keratinization or hyperkeratinization. Again, they can be indicators that the patient has an issue, or is at some stage anyway, bruxing and getting some low-grade irritation on the tissues. And of course, you can go to all the trouble of doing a sleep study where the patients can have these EMGs attached and we can get some recording to see if they actually do Brux. That's a reliable indicator. Suggests that you'd probably do that if you thought your patient had obstructive sleep apnea. Tooth sensitivity, I wouldn't underestimate the impact that bruxism has on that. Sometimes you'll find that patients will say, I've been using Sensodyne or a special type of desensitizing toothpaste, and I still can't get on top of my sensitivity of my teeth. Have a look, palpate the mechanism of the jaw, see if there's any pain there. Do they wake in the morning with an issue with stiffness or tightness of the jaw? Is bruxism an issue, which can also irritate the pulps? And it causes this hypersensitization approach. This is more of an academic one, but some patients have these fantastic lumps on their jaw we call exostoses. This is a genetic condition. It's where they make larger or excessive amounts of bone. We know the palatal torus and obviously the mandibular tori are more common, especially in Caucasians. Palatinus torus, the ones in the roof of the mouth, they're particularly common in Asian populations. But bruxism is thought to be one reason why it's a stimulant, which tends to enlarge in the bone. Now, again, that's an academic reality, not necessarily perhaps practical one in the sense of assessing your patient. So if I saw someone like that, I wouldn't be thinking straight up this person bruxes their teeth. I'd be actually making other judgments as to the fact that it's distributed evenly, it's physiology, not pathology. And you can ask the question, as this was published in 2010, has anyone commented on the grinding? So if you'd had the pleasure of listening to that really loud noise I showed earlier, where the patient was grinding very loudly, sometimes the partner will demonstrate that the patient is actually grinding or clenching their teeth or grinding anyway. So that's really fascinating because that's a bit of academia, but let's talk about reality now, treatment. I mean, how do we manage these patients who have bruxism? We know that the outcome long-term for someone who bruxes depends really on the cause. And we also recognise that the value of intraoral devices we call splints do protect the tooth structure. And even though it does not stop bruxism, it doesn't stop the clenching or grinding of the teeth, it does protect the teeth. And I think that in itself is a valid enough reason to use a splint. So where do we go from here? Well, I think it's fair to say complete arch coverage using a splint, usually a maxillary, is most popular because what it tends to do is when you have the maxillary full upper arch coverage, just by nature of when the patient bites on the device, it actually holds the cheeks and the lips out rather than they tend to bite the cheeks. But there is no difference between value of a lower or upper splint. I think the important thing is to have all the teeth contained in the device to minimise over-eruption, particularly if you have a tooth or a couple of teeth that's not included in the relationship of the setting of the device. I would advocate that you'd make the splint at the centric occlusion, and obviously you want to allow free range of movement. So you don't want a device that's going to contain the mandible. If you tend to contain the mandible, what happens is you tend to increase the workload on the mechanism of the jaw, and for many patients that aggravates TMD symptoms. And the role of the splint really is it does help change patients' behaviour. It does protect the teeth. Now, changing patient behaviour in the sense that sometimes patients will often say during the day when they have their splint on at night, during the day they have this awareness that they're spatially keeping their jaw a little bit apart. Now, one of the hypotheses about how do splints help, that's a useful one, but it's not the only one. I do recommend that you don't encourage your patients to wear the splints during the day, only at night or when they sleep, okay? Because one of the things you don't want to happen is having a device where, in fact, the patient becomes almost like a dental cripple. They can only tolerate the device with their mouth. They get pain-free status. As soon as they take the splint out, try to eat or something, they end up getting pain. And it does actually help manage the unstable occlusion. Remember, folks, we don't attribute occlusion or malocclusion as a cause for bruxism. Bruxism is centrally driven. It's not related to the anatomy of the jaw. It has no bearing on malocclusion. But obviously, in a patient who's got a sore jaw mechanism, having a splint at night and allowing the range of movement of the mandible unrestricted does seem to be a positive, especially in those cases where you may have a multiple unerupted teeth. And the height of the splint, people often ask me, how much separation would I do? What's the interocclusal distance that you'd aim for? I think as a fair estimate, minimum 3 millimetres would be fairly reasonable. And you want all the teeth to contact. So that way, in reality, irrespective of what movement the mandible does at night, and remember too, when the patient's in the chair and they're actually wearing their splint, the way you imagine that they move their mandible, and particularly when you put your articulating paper in the mouth and they do their lateral excursions, protrusive excursions, and just the simple centric occlusion excursions or marks, doesn't always truly reflect how they brux at night. So having a 3 millimetre separation really does, in my view, correlate to some stretching of the masseter muscle, which in regards, I believe, actually helps reduce some of the power of the process. But again, remember, it doesn't stop bruxism process. And everybody watching this would be familiar with the flat plane splint. That's one of my go-tos, as you can see in situ here in the mouth. A Michigan splint, also a main well-known device. Certainly there's advantages in a Michigan. Michigan uses anterior guidance from canine to canine. So as the patient slides laterally, you tend to have a situation where as you're sliding laterally, you're opening up the space between the upper and the lower dental arches. And that's really how a Michigan splint works. We, as I do, tend to use more posterior blocks. This is a new type of splint design I'm working with Race at the moment, where we're actually going to do two designs. The first one is where you have your routine flat plane splint contact, but there are cases where patients who have bruxism issues, particularly waking up in the morning with pain in the jaw, you can actually increase the posterior aspect of the blocks, which you can see from the frontal area here, and that actually biologically stretches more of the masseter muscles, and it seems to, for a lot of patients, improve the outcome as far as reducing pain in the jaw when they awaken in the morning. And I often do go to these type of designs when patients who have a flat plane splint often will say, I wear my splint at night, but I still wake up in the morning with jaw still stiff or sore. First thing I think about is height. How much can I stretch the jaw apart? How much can I actually reduce some of the power of the mechanism of the jaw? And that's the reason why I advocate these posterior blocks. Some people like the Gelb splint. Again, there is no right or wrong splint. My only critique on a Gelb splint might be that in a patient who's got one of these, they're obviously only occluding on the posterior teeth. Their anterior teeth don't touch. I'd be a bit worried about over-eruption. Now, again, people watching what I just showed you with the posterior blocks, people will say, well, hang on, the lower teeth can over-erupt too. Yes, it's possible, but we don't tend to see that very often at all because at least the upper incisors are encapsulated in the device itself and in the design of the device. Now, some colleagues love anterior repositioners splint. It'd be interesting to see people watching this if you use these. I don't. I'm not a fan of it, but again, doesn't mean to say it's wrong. It's just I'm not a fan of it. What it's designed to do is pull the mandible forward. It's particularly useful perhaps for short-term use for about 4 to 6 weeks in somebody who's got pain in the TMJ, and they pulling the mandible slightly forward relieves that symptoms. And it's designed in the mouth to actually, when they wear it, usually most nights and in the day, pulls the mandible forward, relieves some of the pressure. It's also reported to help reduce clicking in the joints, but the evidence behind the value of this is not really strong. And in fact, I want to highlight this because, again, when you make your design of your splint, the idea that you can push discs back into position between the condyle and the fossa, based on the premise that the splint changes things, is not really, strictly speaking, true. And if it is, it's very short term. And that's what they found in this study. So the slide you're looking at the moment looked at a small number of patients, the 32 joints in total. And what they found was about a third, perhaps slightly more than a third, the disc was sitting forward. They had the anterior repositioning splint. The disc on MRI showed it went back into normal position. But 60% of the patients, it certainly wasn't sustainable. The problem you have with this type of approach is you can create posterior open bite in the teeth. And then some colleagues would say, well, we can increase the occlusal vertical dimension, we can add onlays and restorative approaches. From a science point of view, if you don't mind me saying, the evidence base behind the value of doing that is not strong. And I would not advocate that myself. So the advantages of a splint, because you'll always get some smart aleck patient says to you, well, how do you know these work? Well, we kind of know they work because we know that a large number of studies show that the splint does help reduce the symptoms in individuals. When you look at studies looking at huge numbers of patients, they always find that the statistics, they talk about statistical significance, which is relevant because we work in an evidence-based world. They'll say things like, well, there's no real difference between wearing a splint and not wearing a splint. But I think in fairness to everybody watching this, we all know that at an individual level, it does make a difference. And it also gives the patient a chance to do something constructive that they don't have to use it for the rest of their life. In fact, 90% of patients, after 6 to 12 months, we encourage them to start using these devices just when they need to, rather than necessarily every night forever. And so we know that they do protect the teeth. As I said earlier, it does give the patient a chance to start to use the device if they get any pain in their jaw or sensitivity or pain in their teeth. And we also realise that with regards to a splint in general, that we know that, there is no absolute one design that's better than the other. I think it's using common sense. And in my humble opinion, I'd be advocating make sure you have full arch coverage, make sure that whatever you do, the splint doesn't restrict lateral excursions of the mandible. And one of the important things too is that if you make a patient a splint, always check the splint every 6 or 12 months when you review your patient, because they do get uneven from the munching. And it's important that you actually adjust them, polish them if you can, so they're always nice and smooth. And most people, we advocate they start to use the device long-term just when they need to. Thank you.
Thank you very much, Professor Stubbs. It's there's definitely a topic, no doubt, you could speak on for days at a time. I do appreciate the difficulties in reining your knowledge into a half hour, and I appreciated the job you've done there. We do have a couple of questions here. Yep. We have one. When you said to make your splint at centric relation, do you mean at centric occlusion? Do you mean centric relation?
No, I mean centric occlusion. So what I mean is, when I do a bite registration, what I do is I obviously use a spacer between the incisal teeth, and I use jet bite or bite registration material, and I just get the patient to bite down in centric occlusion, because the idea of the devices are that they're flat, smooth surfaces. And so you then allow for variations in the movement of the mandible when they're sleeping at night or when they're using the device.
Okay, I appreciate that. Do you ever incorporate canine guidance into your splints from doctors?
Yeah. Michigan style devices is what the canine guidance would be. What I tend to do is I use more posterior guidance. So I tend to go from 4 to 7. But again, it's just a variation of what you're comfortable to use.
Oh, that's fantastic. Someone's asked if you could go back to your list of drugs so they could take a screenshot if that's okay with you.
No
and just
problem.
while you're going back there, I have a question from actually a real good friend of mine, Dr. Blair Trapman, who has requested upper versus lower.
There's no difference. The only thing is there is no difference actually in outcome for treatment, but the only thing is you'll find that a lot of patients prefer the maxillary arch because it just seems less cumbersome to wear. But what I've observed, and this is just observation, that I've made lots of lower splints, and I found over the years that a lot of patients tended to complain of biting their cheek on the lower splint, whereas with the maxillary arch, it tends to hold the cheeks out the way. You get less cheek trauma.
Okay, that's great news. Are you just taking us back to that drug shot?
Yeah.
When you came there, I know. I'm asking questions, and you're multitasking here, Professor Stubbs.
Under pressure.
I'm
really sorry about that. Please remove the window. I honestly don't know what that is. That's the reference.
That's all right. We can work around that. It hasn't been too much of a problem. Should a splint be recommended after full arch crown and bridge cases have been inserted to protect the restorative work?
That's a great question. And I appreciate that question, actually, because that's debated, but I personally would. Now, the reason I say that is because one of the things we know, and it was published in 2014 by a gentleman by the name of Daniele Manfredini and others, they found that one of the most common attributors to mechanical restorative failure was bruxism. So bruxism didn't necessarily lead to the failure of the implant, but the mechanical restoration it did. So I think it's reasonable if you've got a patient that's spending a large amount of money having magnificent work done to have a guard at night. I think it's quite a reasonable thing.
Does the use of a maxillary occlusal splint make sleep disordered breathing worse? What
Yes.
do you do if patient is not aware of their condition?
Yes, absolutely. Great question. And the answer is yes, it can. And that's why when we talk about sleep bruxism and we talk about, the possibility of a patient having sleep disorder breathing or sleep apnea, one of the things you do is you can ask a series of questions. And I can't recall in the previous talk whether I showed the stop bang, but basically you can ask simple questions like, do they wake in the morning feeling tired? Do they snore? Do they have any reports from partners about stop breathing? They're simple guides, but they're useful to indicate that there may be a problem. In those cases, you would suggest a sleep study before you made the occlusal splint because it does contain the tongue and by nature minimises more of the airway space available. So, yes.
Oh, great question, Koshajala. Look, another, we've got them pouring in. I'm just going to roll a couple more out there. And that's what happens when you ask a professor to jam in half an hour. So what is your opinion on injecting muscle relaxants into the masseters as an adjunct therapy and to help reduce clenching? Yeah,
you're referring to Botox. Look, Botox has its place. I mean, it's one of my go-tos when everything else fails. So I've got patients, for example, where I don't use Botox as my first-line therapy. Obviously, they have a splint. If there's still issues with pain on awakening, I consider a drug called Norflex. Norflex is called ofenadrite, which is actually an antihistamine. As an antihistamine, they take it at night. It's actually quite effective. I find it really relaxes the skeletal muscle, but it doesn't, and it's not a Valium-based drug, so you don't have the sense of dependency. But Botox, one of the problems with Botox, it is expensive. And so realistically, that gentleman I showed the photo of the really hypertrophic masseter muscles, ultimately Botox might be an ideal treatment for that patient because of the bulkiness of the masseters. But, they could be realistically looking at treatment every 3 months, and it might go for a year or longer. And, each treatment's about $600 to $800. So it's not a cheap treatment. But, yes, Botox does have a role. It's certainly not one of my go-tos in my first, say, 3 to 4 levels of therapy. One of my last go-tos.
Okay, Dr. Garwell here has asked, how do you give splints to patients who have to wear their orthodontic retainers at night?
Yes, what I do is, there's the full upper arch, let's imagine if that's what it is, replaces the upper arch retainer, and they still wear their lower retainer. So you accommodate the fitting of the splint to oppose the lower arch in the case of an upper splint, but you accommodate with the retainer in situ, so you can actually allow for that, and that's what I do.
I have never seen many questions like this pouring in, so I'm going to be one more here. A patient on sleep apnea device can use a splint?
You mean a CPAP?
Assuming that's the case, yeah.
But the secret of success, folks, is if you've got a patient on CPAP, you've got to be careful how much do you open up the intraocclusal distance. So my suggestion, no more than 3 millimetres.
Okay, but
because you don't want to compromise lip seal. If they've got a full facial mask, it's not that important then, that's fine. But if they happen to have the nasal ones, which are more popular, definitely you just don't want to compromise their lip seal. So that's where you've got to be careful, just thinking about the amount of intraocclusal distance you're going to open them up.
Oh, wow. So, look, there's that's a plethora. We have run out of time now. It does go to show you the importance of this topic, Professor. We did have well over 150 registrants for this, so it goes to show that the topic is vast and highly sought after, and we all have a lot of information that we do require. So hopefully in the August 10th, everyone, we have a Professor Stubbs coming back again for TMD, or temporamental disorder, and the use of splints in tackling that. So by all means, can everyone from Hong Kong, the UK, Australia, the US, New Zealand, Singapore, who has joined us today, and Malaysia, feel free to join us again on August the 10th. But on behalf of everyone, Professor Stubbs, we'd like to thank you. Your knowledge is unsurpassed, and we look forward to joining you on the 10th of August again for our Academy program webinar series. So I'd like to thank you. Always anything you'd like to finish with us, Professor?
No, I just want to say thank you for the opportunity to come on. It's great, and I'm sorry I had to rush through this. I appreciate that. Maybe in the future we might be able to do something a bit more longer with Race Dental to talk more to colleagues about splints and things, because it is a fascinating area, and most of us in dentistry make occlusal splints, one form or another. So it's a really interesting topical area of discussion.
Yeah, look, I appreciate that. We look forward to having you back on the 10th of August. And anyone wants any more information, give us a call, our customer support team at customersupport@racedental.com.au, or go to our website, racedental.com.au, and make contact for anything you need. Thank you again from lockdown in Sydney. Be safe, and I hope everyone's well. Thank you again, Professor Stubbs.
Thank you very much. See ya.
Be safe. Goodbye.